Good afternoon, everyone, and welcome to today's virtual congressional briefing entitled Expanding Access to Care, the Role of the National Health Service Corps. My name is Tyler Smith, and I'm the Senior Director of Government Relations for the PA Education Association. PAEA, the sponsor of this event, represents all 303 accredited PA education programs throughout the United States, which collectively graduate more than 10,000 new PAs into the workforce each year. The subject of today's briefing is a program of enormous significance to the care of patients and communities across the country, the National Health Service Corps, commonly known as the NHSC. The NHSC was created more than 50 years ago in 1972 in response to an acute shortage of primary care clinicians and in recognition of the critical role of the federal government in addressing this challenge. Through its component scholarship and loan repayment programs, participating clinicians receive educational aid in exchange for a practice commitment in a designated health professional shortage area, durably shaping the distribution of the health workforce for years beyond this initial investment. Now, at a time of growing health workforce shortages, particularly in our most rural and underserved communities, we're facing the additional challenge of an NHSC funding cliff. If Congress does not take action by September 30th, the service agreements of thousands of NHSC clinicians across the country risk being prematurely ended, thereby threatening access to care in every state and congressional district throughout the country. Fortunately, in response to this challenge, congressional champions have signaled their intent to preserve these key investments by introducing a number of proposals to extend and increase mandatory funding for the program, which you'll hear about later in the hour today. Before we discuss legislative proposals, however, you'll hear from several PA NHSC alumni today whose careers have been immeasurably shaped by the doors opened by the NHSC. I'm pleased to be joined today by Shani Fleming as well as Frank Gianelli. Shani is an associate professor at the University of Maryland, Baltimore, and a former NHSC scholar and loan repayment participant. Shani, in her presentation, will then be followed by Frank, who is an assistant professor for the Rutgers University PA program, a former NHSC scholar, and a member of PAEA's Government Relations Steering Committee. I'll then wrap up with a brief discussion of PAEA's policy priorities related to the National Service Corps and opportunities for you and your bosses to advocate for the program and the great work that it does. Should you have any questions today, please feel free to type them in the Q&A box and we can get to them at the end of the presentations. So with that, thank you once again for joining us, and I'll turn it over to Shani to get us started.
Thanks, Tyler. Again, I'm Shani Fleming. Thank you so much for the opportunity to share my experience as one of the almost 70,000 NHSC alumni primary care providers. We can go to the next slide. I have been a PA in the PA profession for over 20 years. I have served as a lifetime advocate for social justice, equity, diversity, and inclusion. I grew up in the DMV, which is a DC, Maryland, Virginia area in Prince George's County, spending the majority of my childhood in medically underserved, under-resourced communities. I had an opportunity to attend the historically Black college, University of Maryland Eastern Shore, which was an outstanding experience. And it exposed me to this career choice of a PA. And once I learned about it, I became hooked and decided that I wanted to return back to the DC area to learn to become a PA. And so I had my eyes set on George Washington University, which is a private university. Great university. They offered a dual degree, which is an MPH and a Master of Health Science, and I thought that it was perfect. But then when I looked at the cost of attending GW, I was deflated, and it was just the number one cost. Cost was a number one barrier for me entering into the PA profession, as it is for many folks who come from backgrounds similar to mine. And so I researched options that were out there for repayment, scholarships and loan repayment, came across NHSC and said, you know what, if it's for me, it will be for me. And I just jumped, and I applied, I got in, I took out loans and just really had my eyes set on the fact that the National Service Corps would help to finance this career for me. So I did, and I applied to NHSC my first year, and I did not get it. And then I applied again, and I received the National Health Service Corps scholarship, which was great, and it took care of my tuition as well as books. I still had the other years that I needed to pay back from my loans. And so after landing a job in a medically underserved area at a National Service Corps approved site, I applied for a National Service Corps loan repayment and received that. And it was outstanding. And so I was able to not only receive a scholarship, but also a loan repayment. You can go to the next slide. So my NHSC experience, once I graduated from George Washington University, again, like I said, I grew up in the DMV, very urban area. My first position was in Boydton, Virginia. Many folks have never heard of it. It's very, very small. It was a rural community. It was by far an amazing experience. I would have never probably elected to go to a site such as this had it not been for NHSC, but it was outstanding. It's 3 hours away from Richmond, and I have family in Richmond, so I was still able to have that support, but was able to sort of generate my own support system within Boydton, Virginia. Just a little bit about that experience. As I drove into the community, there was a huge sign for pig picking that was happening that weekend. I was like, what in the world is a pig picking? I don't want any parts of it. But so very, very rural community. And when I first started, because it's so rural, there was one physician manning the entire clinic. And when I started fresh out of GW, he said, well, I'm going to be taking a 1-month vacation. And so I served as the only provider for that clinic. There were no other clinics within, a very large vicinity, and did well. And it was an outstanding experience. And then after that experience, that's where the service commitment for the scholarship. And then for the loan repayment, I served in Baltimore, Maryland, at the Eastern STD clinic, and I served there for almost 3 years. Outstanding opportunity, and then had my loans paid off. Based off of that experience. And that experience, so serving the underserved in the urban setting, staying connected to other providers that were also committed to serving the underserved, it propelled me into administration as well as research. And then we can go to the final slide. So just to sort of share the impact of the National Service Corps. So not only was I able to serve the underserved community for over 20 years, I was able to, again, I moved into administration, I moved into research and scholarship. I have really committed my life to recruitment, because we know that folks who, similar to me, that come from communities that are under-resourced and underserved tend to return back to those communities. And so I have spent my lifetime on recruiting as many folks coming from those communities as possible into our profession, which is directly linked to the mission of the NHSC. I continue to advocate and promote service in primary care, as well as serving the underserved, and really highlighting quality of that care that's received of our patients, promoting cultural humility, cultural competence of medical providers, which is directly aligned to NHSC. I have served as an ambassador for NHSC. I just try to eliminate that barrier of cost when I am talking to communities that are interested in becoming PAs and want to serve communities, because NHSC, I think without receiving the financial support from NHSC, I would not have really, pursued my career as a PA, and certainly would not have been as successful as I've been. So I am currently still a PA. I am an equity, diversity, and inclusion officer for the University of Maryland, Baltimore. I produce quite a bit of scholarship around equity, diversity, inclusion, really primarily focused on recruiting folks of color and promoting cultural humility so that we can serve in underserved communities, which is directly related to the mission of NHSC. So thank you for the opportunity to share my experience, and I will pass it. Is it Frank?
Yep, that's right. Thank you so much, Shani. Frank.
Of course.
Okay, thank you, Shani. So my name is Frank Gianelli. I have been a physician assistant for the last 10 years. I'm currently in the role of assistant professor at Rutgers University Physician Assistant Program and am the director of the Rutgers Hope Clinic, which is our free clinic for uninsured individuals. Similar to Shani, I was a scholar and did my service in the National Service Corps between 2010 and 2013. Tyler? So a little bit about my background. My background to becoming a PA was a little bit different from Shani's. My undergraduate major was in engineering management, and I focused a lot on project management and really looking at construction as a career. I sort of fell into medicine by mistake. It wasn't what I initially set out to do. But in my time after graduating college, I began volunteering as an EMT in the community, trying to get involved, try to just do some stuff after work, and really began to fall in love with it and really see this as sort of my calling. It was during my time as a volunteer EMT that I really started to think about what it is we were doing on the ambulance. And the vast majority of what we were doing on the ambulance was not taking care of sort of these emergency-based situations that were sort of one-offs. It was a lot of care for folks who were experiencing complications and emergencies from chronic diseases, and many of which, when I was engaging with them, would sort of tell me stories along the lines of, well, I ended up in this position with my diabetes because I couldn't get in to see anybody to get my insulin renewed. My asthma pump ran out, months ago, and that's why, in the heat of the summer, I'm not able to breathe. My blood pressure is super high because I lost my job and didn't have my primary care provider said I couldn't see them anymore because my insurance ran out. And so really what this began to get me thinking about is how I could be involved in the healthcare system on the prevention side versus the emergency side. Many people who start out as EMTs will go into emergency medicine, kind of following along that emergency kind of adrenaline rush and that real desire to kind of stop the immediate. But really, I kind of took it from the other side, which is that so many of these people shouldn't be sitting on an ambulance right now or shouldn't be seeking care at an emergency room because there were better options to take care of these problems and prevent them from getting as complicated as they were. So I left my job in engineering and went into working full-time as an EMT while I started to get my prerequisites for PA school taken care of. To many people's shock, there is no steel or concrete in folks' bodies. So I had a lot of classes to catch up on that engineering school didn't prepare me for. But once I decided to switch my careers and become a physician assistant, I really focused in on primary care as where I wanted to work, and particularly in under-resourced communities that mirrored a lot of the communities that I worked in as an EMT. So I eventually graduated from the University of Medicine and Dentistry of New Jersey, which is now Rutgers Biomedical Health Sciences, in 2013 as a physician assistant, and was getting ready to set off on my career. Tyler. But what became very evident very quickly, and this is something that I think Shani hit on very nicely, is that my career goals didn't match what my kind of debt reality was. I mentioned before that with this career change, my focus was really on reducing barriers to accessing primary care services for the uninsured and underinsured, really thinking about how to keep folks without insurance out of the ERs, out of the hospitals for things that were very easily preventable in the primary care setting. But when I started to think about my undergraduate debt reality, the cost of switching careers, and then starting PA school, my 2013 debt didn't match what a primary care PA salary looked like back then. And so there was a mismatch between what I was looking for in my career and what my reality was. Alan? So I applied to the National Service Corps in the hopes of reducing this barrier to working in primary care. The application process in 2010 looks a lot different than it did today. As many of you are aware, in 2020 with the American Rescue Plan, there was a significant increase in the amount of funding that was dedicated to the National Service Corps, going from a couple hundred millions of dollars to almost $1.2 billion in funding, which really made it so that almost 100% of eligible applicants were able to be funded by the National Health Service Corps. But back in 2010, that wasn't the case. You could see that there was a fraction of the budget allocated for that. And so much smaller percentage of eligible applicants were able to be selected for the National Health Service Corps, which, based on these funding levels and applicants at the time, it was somewhere in the neighborhood of about 10% of eligible applicants being funded for these spots. And what strikes me about this difference is how disappointing it is that there was such a large workforce available and willing to work in underserved communities where there was a primary care shortage, but that the funding to support that workforce and to reduce that major barrier that both Shani and I both described was not able to be done because of the funding that was available, and how far we've come in the last decade in making it so that those that are interested and have a passion and want to work in these communities can, because of this increase in funding. Tyler. So after I was selected to be a scholar, I completed my service at Geneva Community Health in a family medicine setting. Geneva, New York is up in the Finger Lakes region, where we were about an hour and a half from the Canadian border. So very far north in the state. We saw adults, pediatrics, women's health, and we were a true family practice, seeing everyone from 2 days old for their first visit to doing in-home hospice care for folks who actually hit 100. I had a patient who was 100. That was amazing. We had a very diverse population, ranging from year-round residents in the community to migrant farm workers who would, travel up and down the East Coast Migrant Trail, working on the farms. Telehealth was something we were very heavily reliant on in a rural setting, and so specialists, we would telehealth with them to get our patients access to care. And one of the things that was pretty unique about not my particular center in and of itself, but in the network that I was a part of, was there was quite a large interdisciplinary team of physicians, PAs, nurse practitioners, dentists, licensed clinical social workers, nurses, patient navigators, and educators. My particular site was fairly small. It was myself and one other PA who I may or may not have been married to at the time, or married to. We went up, my wife and I were both went up and did the service together, which was an amazing experience. But the vast majority of the clinicians in our network were either current or former National Health Service Corps scholars or loan repayers. And what I think this really illustrates, and a take-home point that I think is important for those in the office or in this meeting right now, is that this interdisciplinary team was made possible by the funding of the National Health Service Corps. This is what brought together all these different professions to come together and to work to really meet the needs of the community we were working in. So upon my completion of my service, I worked at, I took a job as a faculty member at the Rutgers Physician Assistant Program, where I'm currently employed. And I pursued a doctorate of philosophy in urban health systems, allowing some of my research interests and, as Shani mentioned, to really kind of take off and really take part of this new phase in my career. And I'm also currently the director of our free clinic, which takes care of uninsured adults in Plainfield, New Jersey, which is not far from where Rutgers is right now. And really, this new role has allowed me to take a lot of the experiences that I gained in the National Health Service Corps and sort of think about them from a system and a structure level while still continuing to provide care directly to our patients. Okay. So just to mention a little bit about the Hope Clinic. So the Hope Clinic is a free primary care clinic run by the Department of Physician Assistant Studies and Practice at Rutgers. And what we do is we provide free primary care services to uninsured patients in our surrounding community. One of the things that I think is so important about this and the work that's happening here is that similar to what I was doing in the National Health Service Corps, is we're still providing direct care to patients, but through the integration of our students, it's really allowed us to kind of think about the next generation of students and making sure that folks are exposed to uninsured populations, learning by serving and gaining that sort of experience so that, working in a setting such as the FQHCs that Shani and I worked in are, is something that's on their radars. So one of the things I think is also important to take away from both Shani and my experience with the National Health Service Corps is that the investment made in scholars doesn't stop at just the direct service, and that there are multiple points of return on investment for National Service Corps dollars. There's the obvious direct outcome, which is that it puts clinicians in communities that are in need of primary care providers, or at this point, which beyond primary care. I know there's a number of different ways in which scholars can serve now. But then there's also this indirect and career-long and generational connection to community health. You heard from Shanae how she's continued to be an advocate for recruitment for the National Service Corps, and I know she hasn't even sold you on all the things that she's done in her career, that were really enabled by the National Service Corps. But both of us in educational roles have this, the idea of student mentorship. I know at Rutgers, we've had a number of scholars come out of our program in the last, 10 plus years. And so really in this role as educators, it's allowed us to, continue to make those recruitment efforts and reach out to students and connect them to the program for folks who have this interest and still have this continued barrier. We've each taken different leadership roles in clinics and other organizations. So growing from the direct services to really being, advocates and change agents on a clinic level and a leadership level, and then thinking about ways in which we can integrate our research into the problems that continue to face communities that have shortages of primary care providers, and thinking about the systems that help to reduce those barriers in kind of a systematic and structural way, in addition to the direct care that we've provided. Okay. All right, thanks, Tyler.
Absolutely. Thank you so much, Frank. So with all these excellent perspectives in mind, I just wanted to conclude by providing some information on the policy proposals that PAEA has endorsed in both the House and Senate that will really help to ensure that the NHSC has an adequate funding level to address health workforce shortages in communities across the country, and ensure that we don't return to a funding environment where we were turning away the vast majority of applicants that were interested in these programs. So wanted to kick it off with a couple of principles. So at a high level, we believe that these several principles should really guide federal policy from a funding perspective for the National Service Corps. First, we believe that it's critical that any congressional action to strengthen the NHSC begin now. In the absence of congressional action, like I mentioned, mandatory funding for the NHSC is set to lapse on September 30th, so just a few months from now, which is a significant concern given the ongoing commitments that NHSC participants are serving throughout the country. Congress must act quickly in order to prevent this possibility and ensure continuous access to care to patients. Second, funding that Congress authorizes for the NHSC really should maintain the field strength that was made possible through the supplementary funding that was provided to the program in 2021. Having more than 20,000 providers practicing in underserved communities across the country was a significant achievement. Just for reference, we had previously been at about 14,000 before the $800 million provided in the American Rescue Plan Act was approved. And we really should not be backtracking at a time when we're seeing growing provider shortages in communities across the country. And then finally, for the long term, Congress should commit to the principle that if a student or a clinician is committed to practicing in a rural or underserved area, federal assistance will be there to help them to be able to make that decision. As Frank mentioned, due to the cost of health professions education, many graduates are incentivized towards higher paying specialties. So this is really an opportunity for Congress to equip our graduates to be able to make the choice to practice in primary care and in rural and underserved communities. So with these principles in mind, just covering what we've endorsed on the House side, we support HR 3080, which is the Health Center Service Expansion and Provider Shortage Reduction Act. This bill, which is led by Representatives Blunt Rochester, Custer, and Bareham, would provide $480 million in supplemental funding above the current $310 million authorized on a mandatory basis for the next 5 years. This legislation, importantly, would complement another bill that's already advanced through the Energy and Commerce Committee that would provide a level reauthorization of the bill through fiscal year 2028. That bill, for your reference, is the Strengthening Community Care Act. On the Senate side, we've also endorsed bipartisan legislation that, although it has different funding levels and lengths of funding, would also work to preserve the gains made in recent years in terms of building NHSC field strength and the student pipeline. So the bill we've endorsed is S-862, the Restoring America's Healthcare Workforce and Readiness Act. This bill is being led by Senators Durbin and Rubio and would reauthorize mandatory funding for the National Health Service Corps for the next 3 years, steadily increasing funding each year until it reaches an ultimate mandatory level of $825 million in FY26, which, when combined with the supplemental appropriations that the program receives, would approximate where we currently sit in terms of overall funding for the program. So we ask that you urge your bosses to support both of these bills and would really welcome the opportunity to answer any questions you might have. So if you do have questions, please feel free to go ahead and add them in the Q&A box. While we're waiting for questions to come in, we'll kick off the conversation with a couple that we have here. So I know Johnny and Frank, you both spoke a little bit about sort of the calculations that were in your mind when you were picking your specialty choice after graduation. So I was hoping that both of you could talk a little bit about your experiences with current students and some of the disincentives, whether they be financial or otherwise, that might prevent new graduates from practicing in primary care.
That's a great, Frank, I'll start if that's okay. It's a great question. Again, I am teaching PA students, and we have a course on quality and service, and it's a question that I ask of students as far as disincentives to go into primary care, and the number one thing is for them is salary, and it's when, you know, that slide that was so powerful from Frank, when you look at the debt to potential income ratio, there's just such a disconnect that I think that it continues to be a disincentive. Now, that being said, I think there are so many opportunities for PAs to supplement income. And I think that in primary care, I think that, you know, reimbursement and I think salaries are increasing. And that's what I continue to, you know, encourage our students to continue to look into primary care. Especially with so many folks sort of, you know, transitioning out. I think sort of marketing yourself and understanding our value. I think that PAs, you know, don't really know enough around the business of medicine to be able to market themselves appropriately in different primary care settings. But I do think that, you know, initially that, you know, debt to potential income ratio is a disincentive for many new graduates.
Yeah, I agree. I would second that as being the primary reason I hear. The other thing that I hear in addition to that is the idea, and I sort of alluded to this at the end, was the idea that this is sort of there's no room for advancement or growth in a primary care setting, right? In hospital systems, there's leadership, there's all this other stuff. And one of the things that I think I learned as, you know, being a member of the National Service Corps, you know, community, was the number of opportunities there are to be a leader and to be an advocate and to be a change agent in ways that actually may exceed what can be done in a specialty or hospital setting. And so I think that's another untapped secret that I learned during my time in the National Service Corps, and would, you know, also echo as or also would, you know, reemphasize as a benefit of being a part of this program, is that community and those resources of support and growth that actually come from being a part of this. Absolutely.
Looks like we have a couple of questions that have come in from the audience. So one question is, if any of you were impacted by not being informed of your NHSC scholarship until after you started school, and how did this timing play into your decision to attend PA versus med school?
I think it's a great question. Again, like I said, I applied to GW with just a hope and a prayer. And no honesty, it was just I jumped with the hope that I would get it, and I didn't my first time I applied. And I took out loans. I knew that folks did it. I just didn't. It was scary for me to have that amount of debt. So I knew that this was something that I wanted to do, but I just truly just had faith that I was going to be able to qualify for this scholarship or qualify for the loan repayment. I looked at it as though I had two opportunities. If I didn't get the scholarship, then I was definitely going to put everything into loan repayment. So it wasn't necessarily, it didn't deep, I think I was going to pursue it either way, but yeah, but I think that it was a great opportunity. It didn't give me as much anxiety because I felt like I had sort of a safety net.
Yeah, so I agree that was going to be my response too, was thinking about the loan repayment as well, and thinking about it as two different pathways to get to the same place. But I think something that that Shani brought up and that I'm kind of emphasizing here is that the reality is that a lot of it did circle around on the National Service Corps as being an option to do this. This was central. I mean, yes, there are two different programs and two different ways that we could have gotten to the same place. But it does create an era of uncertainty. One thing we didn't comment on in this presentation, but I think that's also important, is that through the scholarship program, you also get a cost of living stipend, which as a graduate student is quite nice. And, I think really does help to sort of readjust the thinking from how is this going to work to, okay, it is working and I can focus in on what I need to be doing to complete PA school. It definitely changes your mindset in that way.
All right. Moving to the next question. This is a question that we always like to get. Has PAEA prepared a draft letter of support that can be used as a template to connect with congressional representatives? The answer to that is absolutely yes. Please check out the Grassroots Action Network on PAEA's website, and that provides you a one-stop shop to connect with your representatives with talking points available on the importance of extending funding for the NHSC. All right. Moving to the next question, and I think Frank, you alluded to a lot of this when you talked about sort of like the importance of the communities that you work with, and also like the networks that you build as an NHSC participant. I'm wondering if both of you can speak to sort of the professional rewards that you've experienced in your career from working with underserved patients, both during your NHSC placements, but then also beyond that.
All right, I'll start this one. So, I mean, I think there were some immediate benefits that I saw. I mean, there's a steep learning curve here. When you become a National Service Corps, in our case, PA, where you have to learn a lot quicker on the job, I think, than some other folks who have, more resources to support them. And so, there's an immediate, I think, professional benefit of really taking ownership a lot quicker. And really, starting to own that. I think, one of the things that I realized was that when you're a PA or whatever in a, under-resourced community where there isn't a lot of access, it doesn't stop at 5 o'clock, right? You're a member of a community, you have this place that is a privileged place. You, as a clinician, have a voice. You have a place where someone will listen. And so you have the opportunities to advocate and to talk to decision makers for communities that other people don't. And so it's not just about what drug are you going to prescribe. It's really about thinking about your patients as members of communities, and communities as having resources and other needs. And so thinking about that from a professional benefit standpoint really, I think, not only changed the way I thought about medicine in the way about approaching primary healthcare, but then also thinking about where I wanted my career to go, to be continuing to have those platforms and spaces to have those conversations.
Mm-hmm.
Yeah, I think that's so true. I think specifically outside of working with underserved patients, but just the rewards of participating in NHSC for me is that it started this, understanding for me of how important it is to work at kind of the national level and be a part of a national project, right? And I think that being a part of a community that's serving so many and having that. So Frank and I will always be connected because we're both NHSC folks, and being a part of a community that's doing something of greater good, I think is just something that's an outstanding sort of reward. And I think that it propelled me to continue to do this, right? So continue to work in sort of national leadership with PAEA and all of these other organizations. So I think that there's definitely something there. I think that it changes the conversation, right? So when we work with under-resourced, underserved communities, we're able to see things that folks that don't work in those communities. So the way that we talk about medicine is different. So Frank working at the Hope Clinic and the things that I, saw within our different communities, there is something about holistic care that it's not secondary. It's just like, that's how we practice medicine. We can't just focus on one aspect of medicine. We have to take everything into account, all of those social determinants of health, because it is so incredibly apparent in our patients that those are the pieces that are more critical than, the physiology behind, something else. And so I think that it just changes the perspective, it changes the conversation. And I just personally, and of course I'm biased because this is where I work, but I think that what we're doing is really going to help push that needle. I think that if PAs specifically could really, lead in this area, then we could absolutely make a difference as it relates to health disparities and health equity.
Absolutely. So, speaking to the point of the impact of social determinants of health, I have a feeling that this might impact your answer on the next question. But as many rewards as there are in working in underserved areas and with underserved communities, there's also a lot of challenges, right, in working with these populations, and also personally, right? So the next question is, what are some of the challenges you faced when you were completing your service commitments?
You want to go for it?
No, you can start. I'll follow you.
So again, I graduated 20 years ago. I started 20 years ago, so it may be different, but a lot of the talk around NHSC was, you're going to end up in Alaska. Like everybody said that, like, you can't find a job, you're going to end up in Alaska or working in like a federal prison system, which is fine. Both will probably be great experiences. But I think that there was a lot of anxiety around, like, am I going to find a site? Am I going to like where I'm working? Is it going to be horrible? So I think that there was a lot of anxiety, which was a challenge for me because life is already hard enough. And then to feel that level of anxiety around what's going to happen next. But it was completely and totally opposite. I had so many opportunities. People actually recruited me. So like even that place in Boynton, like somebody reached out to me when I was completing a rotation in Richmond and said, hey, there's an opportunity here, would you like to come and check it out? And I was like, yeah, sure, So it was so easy and so smooth. And even with the loan repayment, it was so easy. So that wasn't a challenge, but I thought that the anxiety part was. Salary, I think that no matter what, as a new PA, you probably end up taking lower than you really deserve. I think that as PAs, we don't understand our value. So I probably could have made more starting out than I did. Because I didn't understand the value. I had that sort of NHSC thing attached to it. So I was like, all right, I'm just going to take it, but I probably could have got paid more. So I think that was a little bit of a challenge that, I probably felt like I couldn't negotiate as much because it was attached to that commitment, but it's been fine. I mean, I'm doing well now.
Yeah, and so I can relate to that kind of anxiety of where am I gonna end up? How does this work? Will I have any autonomy in my decision? Which again, I did. There's a lot of fear factor out there, which I wish would go away because I think that might be another barrier to kind of signing up for this, which is sort of like I have no control and spoiler alert, us those of us in medicine sort of have that type A need to control what we're doing sort of mentality. But beyond that, I think, some of the challenges I faced in my site, one of the things is by nature, these are resource limited clinics, right? So you don't have all the personnel that you may want to have. I listed a nice list of different professionals. That was across an entire network across most of the Finger Lakes region of upstate New York. That wasn't like, turn to my left and turn to my right, and all these people were sitting around. So, I think there's the real in day-to-day, support, challenge that can exist. And then I think there's also the challenge of I want to but can't, right? Last year we heard from a number of speakers at PAEA that talked about building your toolbox, right, of care, right? What are those tools that you have available to you? And as much as folks across all sectors of the healthcare system like to say they want more tools in their toolbox, going into a national service course and into a community is sometimes like bringing in like a hammer to do like an entire house. It's like you need more tools, and so that's where I think that's really what propelled me to kind of think about where I wanted to go in my career, is to think about how do I be the one who helps get more tools into those toolboxes, because I think that is so much of what your day-to-day challenge involves. It's not the individual patients. It's not, that primary care is, in and of itself. I mean, it's very challenging because of how much you have to do, but the job isn't any more challenging, from a medicine perspective than it is in other places. It's what can I actually use to solve the problems that my community doesn't have, that other communities have, and why the heck not? And then fighting that daily frustration, I think, was the biggest challenge for me. When I was doing my service.
Yeah.
And even today.
So one of the things that makes advocacy for the National Health Service Corps so easy is the significant data that's available in terms of its impact, especially on long-term retention. While the service commitment is obviously required, we traditionally have seen a retention rate of over 80% more than 2 years out post-service commitment. So I'm just curious. I think part of this is probably about the dedication to these communities. I think part of it is probably like the community of NHSC scholars. But I'm curious about why you both think the NHSC has had such a high retention rate and such a great long-term impact well beyond the initial period of federal funding.
Yeah. So here's why I think. Nobody chooses this because they think it's going to be an easy payout. I think sometimes people say, oh, well, they'll just go do the National Service Corps, get their money and run. I don't know who says that, or who's like, I know how I can make an easy buck. I'm going to go do the National Service Corps. I've yet to met somebody who does that. What the National Health Service Corps really does at the end of the day is take people who have personal reasons for doing this, whether it is something like, I'm working in a community that was similar to where I grew up, whether that is I have personal connections to folks who have experienced this. I've had professional experiences with folks who have these experiences. This is an enabler of folks who already want to do this. And so it shouldn't be a surprising, finding that people who want to do this have the barrier to doing it removed, want to continue doing this in some way, or take their career and work on this stuff in a different lens, right? It shouldn't be surprising that we're all circling the same issue if really this was a tool to get us to where we wanted to go in the first place. I don't think people say, well, I wasn't thinking about primary care, but now that scholarship's available, I'll give it a go. Maybe 20% of people do that, I don't know. But that's not how this works, I don't believe.
Yeah, I agree 100%. And I think that you would be miserable, actually, if within those 20%, I think that you would be probably so unhappy. I also think that, it allows you the opportunity to have such a tremendous impact in patients' lives that once you feel that, it's different. It's a completely, it is such this place of service, and you understand, like, so you have this knowledge, but then you're also detective and MacGyver and I'm sure you use your engineering somehow, because you are figuring out these incredibly complex problems, and every day is different. And just to know that you had that much impact, I think that the return on investment is so huge, that I don't think that it's a problem at all. I mean, we self-select. The folks of us who want to do this work, that's who we're applying. And then it's just like, this was a catalyst to help me do the work. And now that I'm in there, I'm able to really do my job and do my job well. And it's something that is unlike any other place in medicine.
Absolutely. And to both your points, I think so much of the National Service Corps, when I talk with students and other alumni about it, is just about removing the barrier that's in the way, right? It's not about radically shifting people's career plans or changing who they are. It's just giving them the leg up they need to do what they're really destined to do. Last couple of questions. So in terms of the application process, we've touched on this a little bit, but I know that we have a fair amount of students that will be watching. So would you have done anything differently in retrospect when going through the application process for the NHSC?
Again, mine was so long ago. And I think that what Frank mentioned is that, so he applied in 2010, I applied in 2000s or so. So a very, very different process. I think that, when I talk to students now, it's just, if this is something that you want to do, so undergrad, start doing things, right? So I volunteered in underserved areas. I made sure that my commitment would be known by the time that I applied. So I think doing things like that, so being proactive in your service would help. But it was a really easy process, I think, at the beginning. I just didn't get it, but I didn't find it incredibly complex.
Yeah, so to echo what was just said, the process itself is one thing, right? But the funding is the other piece of things, right? So, looking in a crystal ball of all Shanae has done throughout her career, it's insane to think that she didn't get a scholarship her first year, right? And that, I think, speaks to funding levels, right? There's a mismatch between qualified candidates or there was, I should say, pre-2020, and there may be in October if we don't act, a major funding gap between interest and qualified and funding for those who can. And so I think that's really the key piece of things here. But I agree, from a reviewer's perspective, there's nothing more of a red flag than saying I want to do this and then having never done it before. So I think that's a really important piece, is to make sure that you're, if you're thinking about your application and putting together an application that shows the qualification, that what you're saying your interests are and saying what you've done matches with what you say you want to do. And I think that's a key piece of things. That matched with the appropriate funding levels, we got a good future. We got a good future ahead of us.
Yeah. All right, and then turning to the last question here, and given how close we are to the funding cliff in September, the issue of National Service Corps funding is just going to get more and more attention over the coming weeks on the Hill. So have a lot of congressional staff in attendance today. So I guess I would just ask you both, if you could leave members of Congress with one key takeaway from everything that we've talked about today, what would it be?
Yeah, I guess for me, there's a direct benefit here to both urban and rural communities. Okay, I know rural communities get a lot of the conversation, and there are quite a bit of needs in rural communities, but this is not parceled out. This is an everywhere problem, and this can be addressed in a bipartisan way, as you saw with the way the bills have been introduced in both the House and the Senate. And the second is to really think about this not only as a short-term investment in the communities, but as we mentioned, 80% continue to go on beyond their 2-year service. And then thinking about the number of ways that there's a return on investment throughout these individuals' careers once they finish their time with the National Service Corps. This is a really good investment with both short-term and long-term benefits.
I would definitely echo that. And I think that if I would leave anything, it's just, the time is now. I think that, leadership, being bold, requires being able to step out there and seeing that this is a win-win in every single level, right? So for patients, for providers, even politically, I think that there are opportunities here to be bold, to lead. The urgency is now. It's critical because we could see what happens without funding. And I just think that in this critical time with these starch health disparities and the impact of access to quality healthcare, that the time is now. And so I think there's no better opportunity for them to lead than to support this funding.
Well, I think that is a perfect note to end on. Thank you so much, Frank and Shani, for your excellent presentations today. And I want to thank everybody who took time out of their busy schedules to join us today for this really valuable conversation that illustrates the impact of policy on the ground and in the health of communities. So I actually just saw a last question come through about having the recording emailed. So yes, we are absolutely planning on doing that. So the recording will be available later today and sent to everyone who registered via email. We'll also go ahead and distribute the slides to everybody who registered. If you have any questions from a policy perspective on the NHSC or any other PAEA's advocacy activities, please don't hesitate to contact me. My name is Tyler Smith again, and my email is tsmith@paeaonline.org. If you want to be connected with Frank or Shani and have any questions for them, please feel free to contact me, and I'm happy to facilitate that connection as well. So thank you all again, and have a great rest of your day.
Thank you, everyone.